Welcome to Westminster Watch. I'm Nick de Bois, and coming up on the show, Britain's National Health Service celebrated its 75th anniversary this year, but it's never faced challenges like the ones before it now. In the wake of the first ever strike by junior doctors and consultants, the NHS is in a battle to cut down wait times, heal patients and keep its staff satisfied. More than 7.4 million people in England are waiting for medical procedures. Everything from hip replacements to cancer surgery. That's up from 4.1 million before the COVID pandemic began in 2020. A recent report from the Commonwealth Fund comparing the healthcare systems of 11 high-income countries found the UK scored well for accessibility and affordability. But our health outcomes are some of the poorest, with the UK ranked second to bottom for avoidable mortality. And there has been an implicit contract between the British people and the state: pay taxes and national insurance contributions in return for a health service that is free at the point of use. But with the tax burden on track to reach its highest sustained level since the NHS was founded, Britons are paying more and more for a service they increasingly cannot access as quickly as they need. Now, let's bring in our panel. Joining us today is Roy Lilly, a health policy analyst and commentator on the National Health Service. Professor Carol Sikora, a physician who's often described, rightly, as a world authority on cancer. And Dr. Bob Gill, a GP and NHS campaigner who created the documentary The Great NHS Heist. Gentlemen, thank you for joining me today. Dr. Gill, perhaps I could just turn to you first of all, if I may. I think we could probably all agree, sitting around here, that the British public are not getting the service that they deserve from the NHS. But both major parties are now saying, and it will appear in their manifestos, that there should be wider engagement with the private sector to ease some of the challenges presently being faced, waiting list amongst them. Now, in your documentary, The Great NHS Heist, you essentially reject growing private sector involvement in the NHS. Why is that?
Well, first of all, I'd like to say this rehashing of working with the private sector, we heard this in 2000 under the Blair-Brown administration. But the fact is, the NHS has been largely privatised in legislation. We've had years of primary legislation which have repurposed the NHS. And now we have an NHS which is spending less and less on the delivery of care, that is employing the staff to deliver the care, on paying for the medicines and paying for the infrastructure, and more money is being diverted into a bloated managerial structure which was necessary to create first an internal market, then a compulsory external market. We have the odious debt of private finance initiative, which was set up as a financial millstone to bleed funding out of the NHS. So we now have an NHS which over the last decade has had relative defunding. If you look at the historical spending increases, the NHS...
Not in recent times, obviously. The last two... I mean, now we're spending record levels, aren't we?
Sure, but we had a boost because of the pandemic, and most of that, guess what happened? It was outsourced. We had a privatised pandemic response. So the historic spending increase for the NHS was around 4%. Over the last decade, pre-pandemic, it was around 1%, and we're diverting money away from patient care. So we have an NHS set up to fail, so that these arguments, oh, we need more private sector involvement, gain traction. But it's a setup, it's a con, and it's against the public interest.
To what purpose?
Well, the purpose,
I mean, it's almost a conspiracy theory in a way, isn't it?
Well, not really.
If you can't explain the purpose.
I can. It's a political ideology, an ideology of neoliberalism, which is laissez-faire capitalism, deregulation, lots of profiteering and deregulation for private companies, low taxation for the rich, and skid row public services for the citizens.
Roy Lilly, you've run a hospital. You will have developed a view of the private sector engagement and role in the NHS and in that hospital in particular. Is it all a big sort of conspiracy theory, as Bob Gill has said?
I don't agree with Bob. I mean, I agree with the direction of his travel. I mean, if we're talking about management in the NHS, it's less than 2% of the turnover. It's one of the smallest amounts that health services, really comparable services, spend on management. So I don't agree with that. If we look at the services that are run by the private sector, he's absolutely right. I mean, it was during the Blair years that really the accelerator was put down on privatisation. Virgin came in, Serco, people like that. They've all gone now because they've not been able to make any money. So, I mean, Richard Branson came in and he was going to tell us how to run the NHS. Where is he now? He's gone. So that didn't work. We actually even gave one of our hospitals to Circle.
Hinchinbrook Hospital.
Absolutely right, Nick. And what happened? After 3 years, they paid £5 million to get out of the contract because they couldn't do it. So there's that element of privatisation. There are other things as well. I mean, at the moment, for example, there's a big push, a political push to use the private sector to get waiting lists down. It's not working. Okay, why is it not working? Well, it's because the private sector are making a lot of money out of self-pay. So, you know, older people perhaps might want a hip operation. It's about £10,000 or £12,000, about 15 maybe. And they're dipping into their pension fund, which they can do now. And so the self-pay element has gone through the roof. And the private sector, the hospitals that, you know, we would look to help us out with some of the elective procedures, they're saying, no thanks, we're not going to do it NHS tariff because we can't make enough money. So I think it's a mixed picture. I don't think I share Bob's clarity. I think it's a much more mixed picture.
Well, could I just come back on one point? You say management cost is 2%. So historically, before the Thatcher government in '79, the spend was around 4%. NHS was considered the cheapest health system to be administered. Then there was work done by Professor Alan Maynard in York University, despite a lot of obstacles, who estimated in 2006 that overhead had gone from 4% to 14%.
When was that?
That was in 2006.
Yes.
So that was Alan Maynard. The structures, the marketing, the bureaucracy has mushroomed since then. So the estimates are around the 20% figure. But
well,
government,
I would say, in fairness, the Commonwealth Fund
dare not release the figures because that's where the money is.
Well, I don't think that's right at all. I mean,
the Commonwealth Fund, if I can add,
yes.
a bit an independent view that regularly looks at these issues across 11 competitive economies, basically said that the NHS is one of the best run administratively, but has some of the worst outcomes at the moment. So, Professor Karasakora, perhaps I could just turn to you a little bit. You deal with patients, don't you? Now, this is getting to the heart of it. Do you think they really care whether it's a private sector provider that's going to sort their procedure out? Aren't they just interested in getting better?
They have no idea most of the time. And in the economies of Europe, where public-private partnerships abound in German, French, Swiss hospitals, they move seamlessly from public to private sector without knowing there's a boundary. I think it's the wrong discussion, really. All healthcare systems are struggling. Aging populations, cost of innovative technology. You can do heart transplants in 80-year-olds now. You couldn't 50 years ago. And then, of course, consumer demand. Dr. Google's out there. People say, oh, this is drug for cancer. We need to get it for grandma. And it's going to cost a lot of money. Who's going to pay? So everyone's struggling. And the private-public debate, whilst it's important, it is probably not the most important thing in terms of healthcare.
But it is in this country, isn't it? It's almost a religion. And yet you talk about European countries, and I'll just press you a little bit on this. If you look at the Dutch model, every single hospital is actually a private hospital, a not-for-profit hospital. They have social insurance that governs this, that is regulated by the state. They bring in high level of private providers. They're top of the league for outcomes in Europe. Doesn't that tell us something?
I think it's efficient. And, you know, in my specialty, cancer, it is ridiculous to have a 2-month target from the diagnosis of the disease and the first treatment. In America, you'd sue the system for making you wait 2 months. And only less than 60% of patients are actually meeting that target now. And there's huge variation around the country. It's really appalling that in the 21st century, you can aspire to a target that is so bad. So I think it's these sorts of things. How can we make it better? I think we have to look at an innovative approach to management and to how to integrate the public and private sectors together. Getting rid of the backlog, as Roy was talking about, from COVID, 8 million people nearly sitting there wanting something. Okay, some of them are double counted, but 8 million is a lot of people waiting. We've got to use every possible avenue to try and get them through the system as quickly as possible.
I have to ask you, we have an annual winter crisis in the UK. I was reading yet again about it being predicted this year. And yet funding, we're not now too dissimilar, either on share of GDP per capita with our European neighbours or our share of GDP period. So the clumsy structure we have at the moment is not serving patients well. Do you think the answer, therefore, is more public sector, when other European countries have a much better mix?
So, first of all, we have to agree as a nation, do we want universal healthcare? Do we want it delivered in the cheapest?
But Holland does.
Hold
These
on.
countries do
Let
have.
me finish my point. If we want the universal healthcare, high standards, delivered in the most cost-effective way, well, a universal system like the NHS, a beverage model, is the way to do it. So we've had consecutive governments actively destroying that model. Now we have a dysfunctional model, wasting billions, as I described, with private finance initiative.
Can I ask you that question? You said they're destroying that access of effectively universal access. How are they destroying it?
Well, having 9 million on a waiting list is pretty good and effective way of destroying access.
It's not a question of asking them to pay for it.
No, but if you close an A&E and you have a critically ill person and you increase their journey time, they're not going to survive. So for that person, that access is gone forever, right? If you keep people languishing on waiting lists, you're going to push to the self-pay. So having waiting lists is denying access. Closing facilities is denying access. Not having enough of a workforce is denying access. But critically, we've had a decimation in the bed capacity. We have the lowest bed capacity per capita in any European or any developed nation, a third of the beds that Germans have. Are we saying the Brits recover three times as fast?
So let's take that point, Roy.
Well, look, Bob's right, but you have to look at the reasons why. And the real damage was done to the NHS in the years following the world banking crisis. Normally, the NHS needs, from about 1948 to today, the average increase that the NHS needs is about 4% per annum. It can get by, expand enough, and do its job. In the years following the world banking crisis, George Osborne was the Chancellor at the time. NHS funding dropped to below 2%. It just can't manage. And it was during that period we didn't recruit enough, train enough, build enough, innovate enough, buy enough. And we went into COVID. This is what we all forget. We went into COVID with 4.5 million people waiting. The damage had been done. And there were 40,000 vacancies in the nursing population alone. And in fact, we couldn't even count them because we didn't count them properly then. Along comes COVID, everything gets thrown up in the air. The government just throw money at it to try to buy their way out of a problem. And now the chickens have come home to roost and we're trying to catch up. So the real structural damage, the NHS, was done in that period. What Bob is talking about with the sort of lurch towards the private sector, that was done during the Blair years. Alan Milburn was the Secretary of State for Health. He pushed the idea of an internal market and everything had to be tendered for. I remember... And
is that part of the problem where we are today, as Bob is contending, or is there effectively a remedy?
Right. Well, let me answer quickly, get Carol's view. But we followed the really disastrous market experiment that cost a fortune and didn't improve anything, with Andrew Lansley's reforms, which disaggregated the NHS, made everything an arm's length body, which didn't work. Now we've got these integrated care boards, which are rather like Carol and I will probably remember because I used to chair one, a district health authority all those years ago. So we're getting back to that model, which makes sense to me. But I think Bob is right. There were two periods in recent NHS history, certainly my memory in the NHS. The market damage was done by Labour, I think, and the structural damage was done by the coalition and later the Conservative Party with their custodianship in that 10 years following the world banking crisis.
I think you asked a key question, Nick. Why do we have winter pressures here when they don't have them in European systems? It's nothing to do with public-private sector, I'm sure. It's not even to do with total capacity. It's to do with social factors. Older people here come out of care homes. They can't go back. They're in hospital for not a week to have antibiotics for a chest infection, but for months because there's nowhere for them to go. And they're sitting in a bed there. You know, we used to call them frequent flyers, but that's no longer politically acceptable. They come in and out of hospital. We've got to do something better. We've got to have intermediate care facilities, not a care home, not a hospital, somewhere which are comfortable. And the people don't want to be in hospital either.
Well, why has this nettle not been grasped? Because I think I'm qualified with my age and not being in the profession. I have heard politicians time after time talk about the ageing demographic, the time bomb that is waiting, the fact that our hospitals many wards are just basically social care wards.
Exactly.
But we're a few hundred yards from Downing Street, where a certain Prime Minister with blonde hair stood on the steps, Boris Johnson stood on the steps of Downing Street, and he said, we have an oven-ready plan for elder care and social care. Where is it? And it's been too difficult.
I think we're also forgetting social care was privatised, right? So privatisation was presented
Was it ever nationalised?
Well, you had 80-90% of provision by local government. Now it's next to nothing,
totally
right?
contracted.
And people are withdrawing from the market.
Yeah, and
now.
you've got big capital funds who go in, asset strip, and then dump what's left on the public sector.
Bob's right.
The problem with private healthcare, Kenneth Arrow, who won the Nobel Prize for Economics, set out what are the problems with private healthcare. Number one, information asymmetry. The patient, as a consumer, cannot have an interaction with an expert because he doesn't have the information to base a decision on. The second problem is the administrative cost. If you have a tax-based system and then you set up a parallel private insurance system or social insurance system, you're immediately doubling.
Well, it works in Holland.
The transaction
cost. It works perfectly well in Holland. I keep coming back to that
and Holland
it's a really important point.
Holland have been spending much more on infrastructure than us for the last 70, 80 years.
Their spending per capita is
the final problem.
No, sorry, this is an important point because we can't just dismiss our learnings from abroad.
The other problem with private care is fraud. There becomes a perverse
But there's
incentive.
fraud in the public sector.
Yeah.
There becomes a perverse incentive to be over-treated, over-investigated, have unnecessary operations
Have you got
that you
evidence
don't need.
to say how extensive that is?
Well, we know in America, the most privatised system,
Okay.
at least 10% goes in fraud, where you have overbilling, double billing.
Who's arguing around here or anywhere to have an American
That is the
system?
elephant in the room.
No, it's not, because
you are
no one's
doing it as
arguing
well.
for the American
You're
system.
diverting our attention to Europe.
Yes, because we can learn from them.
Who was the CEO of the NHS England? Simon Stevens, who came from United Health, America's biggest insurer. What are the systems?
Whoa. Now that's listen. That's
hold on, Bob.
Wait.
You've said a lot.
What are the
Let
systems
Roy
in
come
place?
back
They're
onto
based
that.
on the insurance
Yeah.
model, and these integrated
Bob,
care systems
let Roy come back
are
in.
managed care.
Bob,
They're American
let Roy
systems.
come back in.
They're American systems.
Simon Stevens is a professional manager. He was a Labour councillor when he lived here, and he was the policy advisor to Tony Blair. He's a talented manager, and it's right, he did work for an international American healthcare company. He did a lot to set up primary care in the Far East when he was with them. So I wouldn't like to see Lord Stevens, as he is now, tainted like that. Just coming back to your point briefly, if I may.
How have I tainted him? I just stated fact.
Okay,
He was
Bob.
president for global expansion for United Health.
Bob, there's
the insurance company.
Bob, I'm sorry.
That's a fact.
Bob,
That's not
we have to have a
tainting.
discussion here, okay?
But that's his CV. There's no tainting going on.
If I just finish, coming back to your observation about Holland, a lot of the European healthcare systems are doing better than us. And the reason for that is they didn't have 10 years of pretty much flatline funding. To make the comparisons now about funding is slightly disingenuous in as much as it's been distorted by the investment that the government, or thrown away money, depending how you look at it, over COVID, and that's the tail of that is still running. But if you look at the 10 years that I was talking about a moment or two ago, you'll see that when Europe was putting in 11% of GDP, we were putting under 9%.
In less. But Carol, can I bring that to you specifically with the cancer research report that came out this week, where they actually said the good news is that cancer survival rates have improved compared to 30 years ago quite dramatically. But actually, because of consistent funding, which goes to Roy's point, Denmark has, for example, shot right ahead to us. So there's quite a lot of validity in this argument that we should ignore a little bit about present funding. The history has left us lag behind.
I think it's more than just funding, it's organisation of services. I mean, there's huge delays for everything. And it's variable. So someone can go on a good journey and the same postcode across the road, you go on a bad journey through the system. And that doesn't cost money, it just costs organisation of the system, from primary to secondary to tertiary care. And I think that whether it's public or private is irrelevant, and it's not going to solve it I think we've got to stop loving the concept of an only public NHS. I mean, it's like a church. I'm heretic. I'm branded as a heretic by some of my colleagues because I say things that, well, we could do better here. You're not allowed to say that in certain situations.
Well, is this part of the problem? Because the King's Fund report that looked into effectively, the private sector discussion, it concluded when you compare us with neighbours, and I'm using European neighbours because I think that's the most relevant to us, they're actually saying you don't rip up a model and just replace it with another, because they all have inherent problems. But the problem seems to be here. We get stuck in Bob's debate, which is private evil, public good. And actually, common sense says that's not going to be the result, is it? Why are we not able to change?
Primary care, all GPs are private.
Well, of course.
So, the most important part of the healthcare system, which is primary care, that is run by blokes running their own, men and women running their own businesses.
Well, let me ask this. How would it be better, Bob, if we stopped all our GP practices having a private contract with the NHS? How would the patient be better served?
Well, I would argue with the framing. So from 1948 to 2004, I believe it was, the Blair-Brown changed the contract, fundamentally changed the contract, which within the NHS, GPs had to provide face-to-face consultations. I think it was 26 hours per week, and then admin time. You could only be a doctor to open a surgery. There was an incentive built in to have continuity of care. Your terms and conditions were totally decided by the government. You had an NHS pension. You trained in the NHS.
Yeah, sure.
So to define that as private is ludicrous.
Well, it isn't really, because they make a profit, though.
Let me finish. We don't have shareholders. We can't dodge tax because the government knows exactly what they're paying us. We can't offshore our profits, so we're not like a multinational that does all that.
It's just that's not the case, is it?
Listen, there are companies like Operos, which is an American company, who've bought 80 GP practices and run them private.
That's the 2004 contract change.
There's the Hurley Group, who bought and owned.
So you're making my point. In 2004,
I'm trying to help.
Let him finish.
I haven't explained my point.
You've explained it very clearly, which is why Roy's answering.
Okay.
I'm trying to support the argument here that there were radical changes to the way in which the contract was structured. Actually, at the time, I remember quite clearly, the BMA were quite enthusiastic about creating this greater freedom for GPs to practice. And there is no question about it that you can look at the sort of quality aspect of the idea of family practice as it was then, and now we've got a sort of industrialised primary care. So I think there has been a slide in that concept. But as far as the ownership is concerned, we're seeing more and more practices now being bought and run as conglomerates. And the advantage of that, if I may just say, just as an observer, is that the back office cost of running GP practices, the training, the recruitment, and all that sort of paperwork stuff is taken off of the shoulders of the GPs, run centrally, and
Carol,
doctors can be doctors.
Let me come to you with a final point, if I may, briefly, and then add what you wish. But essentially, hearing the system we've got for GPs, people who are struggling to get to see their GPs, would a change of system change that?
It would. And, you know, I chaired NHS 111 for East London for 3 years recently. And NHS 111 is an answer service. It's very efficient. It deals with a lot of trivia, but it also tries to pick out those cases that need urgent attention. There's no doubt NHS 111 is a godsend, online or by telephone. It is an admission that the system's not working, that you have to have an answer system, which is just an computer algorithm following a program with people that have done 2 weeks training and are paid £15 an hour. I mean, that's not optimal medicine for a country. Europe doesn't have that sort of system.
It doesn't indeed, and we started talking about Europe. I'm afraid we're going to have to conclude talking about Europe. This has gone extremely fast. We have barely uncovered this. I'm sure I'll be inviting you back. So thank you very much, Roy Lilly, joining me, Professor Sikora and Dr. Bob Gill. And thank you, too, for joining me. And don't forget to check out TRT World on YouTube for more lively debate and conversation as witnessed here today. But for now, from me and all the team here, goodbye and thank you for watching